Hello, everyone. It's my distinct pleasure to be here with you virtually today. I would like to thank the organizers of the conference. The topic of my talk today would be the contemporary approach to decongestion in patients with acute heart failure. We'll cover both pharmacological and mechanical methods. These are my disclosures. None of them is directly related to this talk. The outline of my talk would be talking about the congestion and urinary sodium excretion. Then we'll talk about diuretic therapy. We'll add combination diuretic therapy or sequential nephron blockade, and we will end with ultrafiltration for acute heart failure. This is a case of a 65-year-old gentleman who has heart failure with reduced ejection fraction, comes to the hospital with acute decompensated heart failure, and is treated with IV furosemide 80 milligram twice a day, which would be twice the dose that he has at home. The next day, the urine output is marginal at 450 milliliters, and we see that bicarbonate has gone up to 29, and the creatinine is fairly stable. The question would be, which of the following is the best next step? Checking the urine sodium, adding acetazolamide, empagliflozin, hydrochlorothiazide, or starting the patient ultrafiltration. At the end of the talk, we will answer this question based on what we learned during the next 25 minutes or so. So you remember that cardiorenal syndrome has two main arms. This would be the arm that has low cardiac output going to neurohormonal activation and giving us renal dysfunction. And this is the arm on the venous side that will have venous congestion. The right side will give us venous congestion, including renal venous pressure going up, and then that gives us renal dysfunction. And then renal dysfunction on its own can just aggravate cardiac function. So if you remember that congestion is in the midst of everything that we have in acute heart failure, and for the sake of just remembering what we are dealing with, on this side we are talking about low forward flow, and on this side we are having high backward pressure. If you think about it, congestion is a central pathophysiologic mechanism linking renal dysfunction and cardiac dysfunction together. And the majority of the patients, more than 90% of them, come to the hospital because of congestion. We do see patients with low cardiac output, cardiogenic shock, and other forms of presentations for acute heart failure, but the great majority of them are coming to the hospital with signs and symptoms of congestion. Something that is important to remember is that when we are decongesting a patient, this would be the survival, for example. In this study, they put the patient on 2 grams per day of sodium diet, and they decongested the patients, and then they looked at their sodium balance. Obviously, if I have a sodium balance that is positive, my survival would not be as good as somebody who has have a negative sodium balance. The whole point of decongestion would be removing sodium. But what is important in this study is this part of it, that the negative sodium balance will be good even in those patients who have fluid loss as well as positive sodium balance. So basically what it is trying to tell us is that what drives the outcome in these patients is not necessarily fluid loss. It's the sodium that should be removed from the patient. It's important because we typically check urine output, we typically check weight, which are all related to fluid. We don't really know how much sodium we are extracting from the patients who have come to us for acute heart failure. This is something to remember. Another point about decongestion in patients with acute heart failure is that many of these patients Day one, they have very good just urine output. But as soon as the day one is passed, you see that urine output goes down. If you adjust this for the amount of diuretic that they get, you'll see a different picture. It's here. When it is adjusted for milligram of bumetanide in this study, then you see that you don't see a major decline in urine output. Is it the same for sodium? It's not. Urine sodium comes down after the first 24 hours, and even when you adjust it for the amount of diuretic that you give, still you see that urinary sodium there is a decline. So basically, what this is trying to tell us is that with diuretics, when we start them, we have a good response in terms of natriuresis, but then it declines over time, unfortunately. That's why the current paradigm, there has been a shift. In the past, we looked at the patients that came with acute heart failure. We're looking for the traditional markers of decongestion, such as weight, urine output, intake output, right? It has changed. Now we are going to check urine sodium, and this is how we are going to treat the patients. We are going to see it soon, that if the urine sodium is up or it is high, we are in a good shape, that congestion will happen and the patient will be discharged. But if urine sodium is low, we are going to have worsening heart failure or even higher mortality. These are just an example of the studies that have looked at how we can use urine sodium to guide our treatment of acute heart failure. We are going to take a look at a couple of them. The first one is PUSH AHF trial. They basically wanted to see if they guide their treatment by urinary sodium, do they have a more efficient decongestion? And they did. This is the patients who were just guided by conventional markers that I mentioned to you, and these are the patients that had urinary sodium guidance. And you will see that the 24-hour urine sodium excretion was much higher in this group. Unfortunately, when you look at the mortality at 6 months, you don't see much difference. And it just tells you that after the patient is discharged, mm, post hospitalization for acute heart failure, there are competing factors that will come into play that might not be the only thing that will be important, would be decongestion. There are other factors that will affect the survival of the patient. In the ENACT heart failure trial, they saw pretty much the same pattern. Those who had standard of care had 174 millimole of sodium removed on day one, while those who had been guided through their urinary sodium, then you will see that the urine sodium was much higher, more than 60% increase in urinary sodium excretion. Cumulative natriuresis was also higher, and cumulative diuresis was also higher in this study. So it just tells us that if you use urinary sodium, you get a better decongestion for patients who are coming for acute heart failure. And that is why the new algorithm for acute heart failure, and it is newer than the previous one, obviously, but it's been out for a few years now. It tells us that after 2 hours, 6 hours, or maybe a few times during the first day of treatment, why don't you check the urine sodium and let that guide the next steps in you? And in general, we like the urinary sodium to be more than 50 to 70 millimole per liter. So this would be the number that we have in mind. And actually, believe it or not, this has been the basis for the definition of diuretic resistance. If you give a patient the optimal diuretic dose, and then 2 or 6 hours later you check their urine sodium and it is less than 50 or 70 millimole per liter, they are likely to have diuretic resistance. The next point about diuretic therapy in patients with acute heart failure is the eternal questions we have had. Is it better to use furosemide or torsemide? Currently, the majority of the patients are being treated with furosemide, more than 80%, and torsemide and bumetanide are really not that high, the usage compared to furosemide, less than 10%. We have always been told that there are several advantages for using torsemide, however. If you remember, there have been preclinical data and clinical data. And the clinical data, it tells us that, hey, with torsemide, you will have less RAS activation. And as you remember, RAS activation is a target of therapy. So if you have less activation, it's always beneficial. They say that improved diuresis and weight reduction also can be seen by it, and a number of other factors such as decreased length of stay. But they have been all proposed. Finally, in 2023, we had a study who really looked at it in a randomized controlled fashion. In more than 2,800 patients, they compared torsemide versus furosemide in those patients who had an episode of acute heart failure and were discharged. So after hospitalization, the patients were either receiving torsemide or furosemide. You see that they're pretty much overlapping in terms of mortality after the discharge over the next 30 months. So at least based on the current evidence, we can say that there is not much difference in terms of furosemide or torsemide. Is there any difference in patients with a GFR that is lower? We have always been thinking that torsemide might have a better bioavailability, right? It doesn't seem so. At least in this study, when they looked at the subgroup analysis, patients depending on their eGFR, there was no real difference between the groups that had lower GFR in terms of response to torsemide versus furosemide. This is transform heart failure trial. Another aspect of pharmacologic therapy in patients with acute heart failure would be combination diuretic therapy. As you remember, the sodium absorption is happening. The first part would be in proximal tubules, around 65%, and a second major one would be in the loop of Henle, the thick ascending segment of the loop, which is 25%. So almost less than 1% will be excreting. That's why the FINA is less than 1% typically. What if we have a patient on diuretic? As you all remember, in the distal tubule and collecting duct, we will have a number of channels just super active, which will give us some form of diuretic resistance. Basically, after we blocked with loop diuretics the absorption of sodium, there will be more sodium absorbed in the distal parts of the nephron. And this is why we think that the compensatory sodium absorption almost constitutes 79% of the cases of diuretic resistance. So how can we just counter this diuretic resistance? There have been a number of methods that have been tried, natriuretic and dopamine. They didn't really pan out. Hypertonic saline is something that has been discussed, but there is no real answer about it. The evidence is not enough. We have sequential nephron blockade and extracorporeal ultrafiltration that might be of help. Sequential nephron blockade tells us that you can use the loop diuretics as your key diuretic therapy, and then you add any of these or some of these together: SGLT2 inhibitors, carbonic anhydrase inhibitors, thiazides, MRAs, and VAPTANs or V2 receptor antagonists. I am not going through all the details of it. I have previously published it. If you are interested, you can take a look at the paper in CJSN. what I put there over there is that different mechanisms and different clinical studies, randomized controlled trials that have looked at it. For example, here is the chlorotic trial, which used hydrochlorothiazide added to loop diuretics, or this is EMPA response, for example, that the SGLT2 inhibitors added to loop diuretics. And here, as you know, SGLT2 inhibitors are used as diuretics, not as the quadruple therapy that we use. That basically they can be used both ways. It just tells you that not only they are part of the GDMT, but they can be started during the admission to help improve natriuresis and diuresis. So the result of those studies, just to summarize some of them, is that in terms of urine output, if you look at this, this is the loop diuretic and the green is the intervention, meaning that the combination therapy. So the red is always the loop. As you see here, different studies have been here, V2 receptor antagonists and all those. When you see the difference between the two columns, it tells you how efficient they are. You realize that the biggest difference in urine output is for SGLT2 inhibitors and probably the Vaptans. The problem with Vaptans, as you know, is that they remove water but not sodium. So in terms of congestion for weight and all those, they are good, but because the main um, target in decongestion is sodium removal, as I showed you in earlier slides, they have not been shown to be very effective in this setting. When you look at the urine sodium, you see a different story. While there are several possibilities, again, the red is loop diuretic, the green is what we call the intervention arm, meaning that something has been added to it. We are surprised to see that actually thiazides seem to be doing fine, but the main one that is good is ultrafiltration, and this is not added to diuretics, it's instead of diuretics. Basically, as you know, ultrafiltration removes isotonic fluid. So the fluid that we remove is around 140 millimole per liter of sodium or so, depending on what the serum sodium of the patient is. While the diuretics, the loop diuretics, are typically around 60 to 80, 85 millimole per liter. So almost twice as much we are taking sodium with the same amount of fluid. That makes ultrafiltration a very, I would say, interesting option in this setting because of efficient decongestion that it offers. And this takes us to the next uh, part, which is the last part of my talk, about extracorporeal ultrafiltration. So what do the clinical trials show about using ultrafiltration or mechanical removal of fluid in patients with acute heart failure? Let's look at two landmark studies. Unload trial published in 2007, Caris heart failure was published in 2012. Well, they are different and differences are written here, but probably the first and the last one are the most important one. Unload was done in patients with acute heart failure, 200 patients. Caris heart failure was done in patients who had acute heart failure and worsening renal function. So these patients had acute cardiorenal syndrome. And another important difference between the two was the way ultrafiltration was done. In Unload trial, they used flexible ultrafiltration depending on the clinical needs and the characteristics of the patients. They changed the ultrafiltration rate. While in Caris heart failure, they just performed fixed ultrafiltration rate of 200 milliliters per hour. So what did we find? In the Unload trial, what we saw was that the decongestion was much better with ultrafiltration compared to diuretics. You see the weight loss here with ultrafiltration compared to diuretics. But when they looked at the rise in serum creatinine, they saw that they increased the serum creatinine the same way. What about Caris heart failure? In Caris heart failure, the decongestion was the same. This is the weight loss, and you see that they are pretty much in the same way. But in this study, actually, rise in serum creatinine was more common in patients with ultrafiltration. Actually, the study stopped because of this. There was a per protocol analysis because there was a lot of crossover in this study. So a per protocol analysis was published almost 6 years later, as a matter of fact, and it showed that if we look at what treatment every patient got, not the intention to treat, just what the patient really got, we see the same pattern that the fluid loss is always there with ultrafiltration, the net fluid loss, the total fluid loss, and also the weight compared to baseline. They're all better with ultrafiltration compared to diuretics. And it's obvious. With ultrafiltration, you decide how much fluid you take. So it is under your control, as opposed to diuretics, when you apply some dose and then you wait to see how much the patient is going to make urine. So decongestion, when you look at the per protocol analysis of cardiac heart failure, it seems that it has the same pattern of previous ultrafiltration trials. Ultrafiltration is better than diuretics. What about the rise in serum creatinine that it showed? So as you know, this is old news now, and I chose a paper in 2012, but you know that up until last year, we have several studies that are showing the same thing, that the rise in serum creatinine might not be a bad sign in patients who are being decongested in acute heart failure. So here in this study, we have worsening renal function or rise in serum creatinine. If we have a rise in serum creatinine and the patient is congested, obviously these patients have worse survival. But as soon as we have decongestion, then worsening renal function does not seem to be a major issue. In other words, what drives the outcome is not the rise in serum creatinine, it is persistence of congestion. To answer the questions better, that the ultrafiltration was different, the patient population was different, and all those, Avoid Heart Failure tried to combine all these together. In 2016, it came out and it had acute heart failure in more than 224 patients. Unfortunately, it had to be stopped prematurely. More than 800 patients were scheduled to be enrolled, but it did not happen, so the sponsor stopped it prematurely. It had adjustable ultrafiltration, just similar to unload trial. And it had early ultrafiltration. Within 24 hours, the patients received. You see that there was a difference when you look at the trial, the survival. Loop diuretics, the survival was much lower than, much smaller than the ultrafiltration. But first of all, it was not statistically significant. And again, because the number of patients was only 200 when it was planned to be more than 800, the power is not sure that it can show any real difference. We just can say that the trend is pretty much the same as what we have seen with other ultrafiltration trials. We can remove more ultrafiltration. Heart failure events were lower with ultrafiltration, and rise in serum creatinine was not different. And again, we remember that rising serum creatinine, we are not sure what it exactly means. It is not necessarily a bad sign if the patients are being decongested. And when you look at the algorithm for ultrafiltration therapy to see what they really did, it is very detailed. Obviously, I don't want to go through the details of it. What I'm trying to say is that it has been a very well thought study. They had, for every part of it, they had a specific plan. When you look at the average ultrafiltration rate, they ended up with much lower than what they had planned, 138 meters per hour for 80 hours. And if you look at the ultrafiltration rates that they were starting, even the lowest part that they had started was 150. It tells you that they had lowered the ultrafiltration because of different reasons, probably including low blood pressure. That is something that we need to remember if we want to use ultrafiltration. So what would be the optimal ultrafiltration protocol for patients with acute heart failure based on all these studies? First of all, recurrent admissions. The first thing that ultrafiltration has shown is that just the number of admissions will come down. Early initiation is important. You don't wait several days or sometimes a couple of weeks before you do ultrafiltration. If you plan to do it, it's better to do it earlier. Withholding diuretics, the Italian studies did not stop it. The American and Canadian studies, they stopped it. So most people try to use either ultrafiltration or diuretic, not both of them at the same time, using low ultrafiltration rate. I talked about it, customizing to the need of the uh, patient at the beginning and then revisiting it afterwards, and more importantly, objectively monitor decongestion. Over the last few years, I have offered that point of care ultrasound might be great in this setting. So let's go back to our case. This was a case of acute heart failure. We used IV furosemide 80 milligrams twice a day, marginal urine output, and these are the numbers. Then I asked which of the following is the best next step. So if you look at any of these studies, any of these steps, there is a study that kind of backs it up. Uh, Urine output, checking it, push heart failure, and other Natriuresis-guided trials tell you that use the urine sodium. Obviously, here they did a little bit late if they do it after 24 hours, but it still is meaningful. Adverb, definitely this patient would benefit from it because the bicarbonate has gone up and the potassium is not low. So he would he would definitely be a good candidate for CAI or carbonic anhydrase inhibitors, Diamox or acetazolamide. Empagliflozin definitely would be a good choice for this patient. Chlorotic, I'm not sure because the bicarb is 29, but you cannot say that it cannot be used. That's the most commonly used combination treatment. For ultrafiltration, I think that if you plan to ultrafiltrate the patient, you shouldn't wait long, and this would be the right time to do it. Although, arguably, you might want to treat still this patient with diuretics to ensure that diuretics alone will not be enough. And with this, I would like to thank you for your attention. It's been a pleasure to be here with you. I hope you will have a great rest of the day.